Hello everyone, and welcome to the last lecture in the Geriatric Health Promotion Lecture Series, sponsored by the Northwest Geriatric Education Center. My name is Barbara Cochran. I'm the director of the DeTournier Center for Healthy Aging, and I'm representing the Northwest GEC today. A reminder that these lecture series are posted or will be posted on our nwgec.org website. Probably within the next couple of weeks they'll all be up there. So take a look, along with lectures from other series available for free, just a quick registration so that we can count numbers for our funding agency. Today we're very happy to have our closing lecture with Dr. Wayne McCormick, who is a very popular speaker for this series. Dr. McCormick is a professor of gerontology and geriatric medicine here in UW and Harborview Medical Center specifically. He is board certified in internal medicine, preventive medicine, public health, palliative medicine, and geriatrics. He is medical director of Bailey Boucher House and section chief of the UW Academic Long-Term Care Services. And he's Chief Medical Officer for Hospice of Seattle, so incredible expertise. He's also this year president of the American Geriatric Society, so I don't know where he finds the time to do all of this. His research interests focus on long-term care for persons with AIDS and persons with Alzheimer's disease. He has tremendous expertise on our topic today, the POLST, Exploring Practical Aspects. Welcome.
Thanks, Barb. And thanks.
You might want to mention about the chat at the end.
Yeah, sure. Okay. Thanks for having me again. We're going to talk about the provider or physician orders for life-sustaining treatment, or POLST, today. And the audience is composed of people from multiple states. And so things are probably going to vary some from state to state, including the name of the POLST. In some states or areas, it's called a MOLST, Medical Orders for Life-Sustaining Treatment. There's a MOST and any number of other acronyms. The idea is the same, that it's a document showing agreement by signature between a patient or their surrogate and their provider, should be a doctor or nurse practitioner or somebody else, depending on the state and the regional rules, about their advance directives. The idea being that both of you are agreeing in writing to certain types of advance directives. So we're going to go over that, and about 4:30 or so, we're going to run through half a dozen cases or so. So I'm going to ask you all to feed in questions or comments about the cases. Each one is a conundrum of sorts, which will outline how things can go awry sometimes with the POLST, or with any advance directive, really. The devil's in the details. So let's go ahead and talk a little bit about the history and research behind this advance directive, or POLST, and then we'll do some cases. The POLST is an advance directive, so it's all about advanced care planning. It's just one example of an advance directive, not unlike other ones. The difference being it's real simple, fits on one page, and it has the signatures of not just the patient or their surrogate, but also a provider. There has been a lot of research that the POLST in concept is about 2 to 3 decades old. There's been quite a bit of research around the country about it, and actually it's part of a national database and an investigative enterprise, which I'll talk about a little bit later. After we go through that, we'll do the cases. So again, there's several different types of these. This is an ancient form from around 1990, which outlines what the POLST is. At the top, there's always a decision to either receive CPR or not. And then what follows is a general breakdown of whether you want comfort measures only after you've decided about whether you want CPR or not, whether you want limited interventions, that is not full resuscitative or rehabilitative measures, but something in between, or whether you want full treatment and resuscitation. Section C has to do with whether you want antibiotics or not and in what situations. And Section D is a bit about whether you want artificially delivered nutrition and fluids. And then E is who actually is filling out the form. Is it the patient? Is it a relative, significant other, durable power of attorney, guardian, etc.? Many people agree that the POLST initiative began in Oregon in the early 90s. And it was formally rolled out about then. The idea was to have it on one page, have it simple, have it in a day-glow color, whether it's pink or green or whatever, so that people could easily see it. And it generally be used for seriously ill people, although it could be by somebody who's completely healthy if they wanted to make sure that if they knew what their advance directives were and wanted it outlined. Signed by both provider and patient. It turns patient preferences and advance directives into an order, but that doesn't mean it necessarily has any more power than the usual advance directive. I don't know about you all around the country, but I give people orders all the time that they decide not to follow. So I'm not sure how powerful it is as an intervention, but we'll talk a little bit about that. But the idea is to ensure that the wishes of that individual for treatment are honored. Whether that comes to pass or not, we'll go over a few cases. Now, how does it differ from a living will or a different kind of advance directive? Well, again, the POLST was designed for seriously ill people, but again, perfectly healthy people use the POLST form too. I have any number of patients who actually don't have any serious medical condition, but who want to have a POLST form. So that's changed a little bit over time. Living wills for every living adult. And a living will often requires decisions about myriad future treatments, kind of a nebulous realm, and consequently a lot of living wills or advance directives have a nebulous kind of read what you want into it nature. But generally speaking, the idea is to provide a fairly clear statement of people's preferences. Most advance directives aren't necessarily accessible when you need them. They might not be in the medical record of an ER or a hospital where you might end up if you're found on the street or something or get hit by a bus. They're often at home somewhere, maybe in a file, or maybe at someone's attorney's office. So it has to be retrieved, and because they can be somewhat nebulous, they might need interpretation. The POLST is a little more straightforward, where you're just checking boxes down a sheet. The patient keeps it, but the idea of having it day glow is, especially for patients who are seriously ill, that they'll paste it in a prominent section, or maybe make copies and put it around the house, maybe on the fridge, on the back side of the front door, wherever is going to be most prominent that anybody entering the living quarters would see it. Or in the medical record. It's prominent, day glow color, people will see it. And again, it's a provider order in addition to the patient's order. The core requirements are that it is a medical order, that there's a targeted population, and the patient or their legal surrogate can sign it. It breaks down the different treatment realms, CPR or not, and then these other orders I alluded to. It stays with the patient, and there's a training component to it. So here's a POLST form blown up a little bit for you with the different realms. And even this one's a little older. It continues to undergo revision. This one is from about a decade ago, and it is one that was commonly used in Oregon at the time. Since then, they've become day-glow orange and day-glow green. You probably have seen some of those before if you use them in your area. You can see it's pretty simple. I mean, when you have a living will, often it's a few pages of prose, of text. This is kind of more telegraphic. And again, the top decision is CPR or not. These days, this has been resolved a bit. I think you can all probably see on your screens that on your left is the, yes, do resuscitate me. I do want CPR. and to the right, do not attempt resuscitation. Nowadays, it actually includes another phrase that says allow natural death, which I kind of like. I like it when I'm counseling patients through the POLST form, that rather than here's what we're not going to do for you, here's what we're going to do for you. We're going to embrace that you may be near the end of life, and we're going to allow natural death rather than withholding something from it. I think that resonates a little bit better. Once that decision's made, then you go through this comfort measures only, limited interventions, or full treatment in the other realms. It turns out there's pretty good adherence with the top two boxes, a little bit less so with the antibiotics, and again, fair adherence with D. Well, we'll talk a little bit about that in a second when I show you the results of some research. But you see down at the bottom that it's signed by both people, the surrogate and the provider. Now, again, this is where the devil's in the details. Some states allow nurse practitioners to sign them. Other states don't. Some states allow the patient only to sign them and will acknowledge them if just the patient or surrogate sign them and not the provider. Other states, no good. And even within micro environments, people differ and vary about what's okay and what's not about a POLST form. Just one of the many issues that can come up with them. Here's the back of Oregon's POLST form, circa about 2000. And that is that you can change it. You can complete it and then use it, and then if you review it or want to change it, you can. And on the newer forms, there's actually a kind of a set of boxes where you can change things and date them along the way so that they're up to date. So that's handy, and that's a new revision that's a good idea. So let's talk a little bit about some of the research results. Since the POLST has been around for a quarter of a century, people have looked into whether the darn thing works or not. And the results have been a little bit variable, but getting better over time, especially as it rolls out across the country and permeates medical practice a little more than it used to. One of the first studies were focus groups about whether the POLST works very well or not, just among citizens, patients who might use it. And they thought that the POLST generally improved agreement with patients' wishes, and that others, other family members, people around them, could acknowledge and agree with what the patient wished more often, because it was less subject to interpretation, a little bit more codified and clear-cut. A couple of years later, this was a study of using the POLST form in a nursing home. And it turned out that there was excellent performance about if a resident did not want resuscitation and wanted comfort measures only, then that's what was acknowledged. None of these 180 nursing home residents received CPR if they had indicated on their POLST that they did not want it. So that looks like it works pretty well in nursing home residents. Now that's a rarefied environment where it was being used as the advance directive in the nursing home, and the staff had been in-serviced about it, so no surprise that they were able to acknowledge it. But that's great. Nothing wrong with that. It works pretty well in nursing homes. Then 14 years ago, this was in non-nursing home frail elderly, wishes were followed pretty well about CPR, although not 100%, 91%. Pretty well for antibiotics, 86%, a little less for IV fluids, and better again for feeding tubes. That'll play out more in the future as well. Interestingly enough, as time has gone on, the adherence to the antibiotic section has fallen. These days it's only about 50-50, indicating that part of the POLST form maybe is a little bit wishy-washy and not necessarily all that important, really, to lay public and providers. So people tend to not adhere to that section of the POLST quite as well. But CPR and tube feeding, consistently, it's been excellent adherence over time. Just a decade ago, 96% of Oregon nursing homes report POLST guidelines, decisions, and evolved to care standard. In other words, almost all nursing homes in Oregon use the POLST form as their advanced directive. Now, people can put their living will or other advanced directives in the nursing home chart too. That's fine. You don't have to throw those away if you have a POLST form. That's fine. But it's just that as a matter of course, for common practice and in-servicing, almost all nursing homes in Oregon use the POLST form. But that's kind of good, because nursing home staff tend to move around between one nursing home and another. And it's good to have common practice across places. Same year, 3/4 of residents who wanted no CPR or wanted to be DNR wanted some additional interventions, like antibiotics or other kinds of things, not comfort measures only. About half wanted some kind of limitations, conversely. Half of people who chose to receive CPR wanted to be full code, did want their care limited in some way. And here's an interesting study, again a decade ago. Oregon emergency medical technicians indicated that if they saw a POLST, that it changed their practice in almost half of patients. In other words, if they had something to go on, they would change what they would normally do, and maybe would do more limited interventions or not resuscitate somebody or change their protocol if they saw a POLST form that indicated what the person wanted. Otherwise, they just do their thing. Again, same year, the POLST agrees with advanced directives in Washington nursing home residents and had a high satisfaction rate. Here the N is actually facilities, not people. So that's good. So you see, this is kind of a history of how the practice has evolved. It's almost a study in change management, at least in Oregon and Washington, but you'll see how this rolls out in the rest of the country as well over time here. Just a few years ago, almost all Oregon nursing homes report treatment is consistent with POLST. In other words, they all use it, and the treatment is well consistent with it. Almost all with the CPR, but not 100%. Almost all with interventions. And again, it slid a little bit with tube feedings and the no antibiotics piece. Those have changed a bit. So the adherence is less tight with tube feeds and antibiotics as the POLST has become more common practice. And again, this is the back and forth again. Half of people who want no code want some other things done if they're very ill, and 1/4 of people who want CPR may want limitations of therapy, or they may want comfort measures only. In other words, they might want to be resuscitated, but then don't want other aggressive interventions necessarily. We'll talk about why that might be okay depending on the situation. You folks listening may think that, well, that doesn't jive. That's inconsistent. Might be. Let's think it through. Last year, most California hospitals have POLST policies and forms, have educated staff, and have high compliance in the emergency room. These are California hospitals. Doesn't say they use the POLST as their form. It says they comply with it when somebody shows up in the ER. It's a bit different. So it's after 4:20, and now is Haley back there? I'm gonna ask for folks to kind of respond to these questions in format. Professor Cochran is here, and she'll field your input, and if you don't have any input, I'll tell you a little bit about what happened, but we have quite a few cases here to go through. I think it'd be kind of fun to talk about them across the country. Maybe before we even do those cases, I'll wait a minute, and if you wouldn't mind, around the Northwest, why don't you let us know here in the room whether you are using the POLST, if you use some other form like the MOLST or the MOST, if your practice environment is actually using it or recognizing it, whether nurse practitioners can sign it in addition to other MDs or others, those kinds of things. Are you using the POLST? Are you familiar with it? Send us a little feedback on that, and I'll read them back. Barbara and I will as they come in. I'll see what you say. In the meantime, I'll let you read this case.
Montana VA uses POLST forms.
Montana VA uses the POLST form. That's interesting because the VA is essentially an embedded National Health Service in a way. And so you might imagine that POLST forms could pervade the VA system maybe easier than other parts of the U.S. healthcare system. And palliative medicine is a funded mandate within the VA. So again, probably helps with that kind of dissemination.
So Olympic Medical Center uses the POLST. Alaska uses the MOST form. And in Sequim, Washington, it's a regular question at patient clinic visits and regular use in skilled facilities. Alaska is also in Seward and Fairbanks use the MOST, and they say a nurse practitioner can write the order.
Great. Can they hear you, Barb?
Yes, they can.
Okay, so I don't have to repeat.
Right.
Okay. So that's pretty good. Most folks are using it or recognizing it. A little bit variation. That's terrific. Well, let's get your feedback on this one, on this case. This is the story of a 90-year-old man. He has advanced renal failure. He's been on dialysis for over a year. He also has fairly significant cognitive impairment, although he doesn't formally carry the diagnosis of dementia. He has a dementia syndrome. Probably multifactorial from cardiovascular disease, cerebrovascular disease, and alcoholism. He's had severe vascular disease, coronary artery disease, and peripheral vascular disease. He's admitted to the hospital from the kidney center with pneumonia. So he's really pretty ill. He's got pretty bad multimorbidity, and now he's got a pretty bad pneumonia coming in from the dialysis center, pretty sick, to the ER from the kidney center, and he's with his POLST form, which is actually on file at the kidney center, which indicates do not resuscitate in the top box of the POLST form and full treatment underneath. Doesn't want to be resuscitated, but wants everything done. What do you think about that? Just comments or questions. Do you think that is inconsistent, not logical, or can you see how that could be, could actually accurately reflect his and his loved one and or his loved one's wishes and might be a consistent advance directive? Any comments about that one? Go ahead, I'll repeat.
I'd say up until about the time you put them on life support, it makes sense to me.
That we have a comment from a member present that up until the point you're thinking about putting somebody on life support, it makes sense.
Yeah, I mean, I don't work in that sort of environment, but I think there's a gradation there where you may not have done CPR, but you put them on a breathing machine or something.
So the idea is you may not do CPR on the guy, but if he has pneumonia, and let's say you're at the bedside and you think, you know what, if this guy get antibiotics, he's pretty darn sick right now, but he could recover in a day or two. We can see how it goes. But right now he needs ventilatory support. And his POLST form indicates that he'd want that. He can't really speak for himself. So it might be consistent. He might not want to be one of these deals where, well, if I'm dead, don't bring me back. But if I've got something might turn around, I'd be okay being on the ventilator a little while in case I might get better.
So someone has said, sounds like someone should talk with the family or power of attorney.
Yeah, great suggestion to, if it seems like even if you feel like this is consistent and actionable, which is totally legit, you still might say, well, let's reach out to the family and get them on board, and let's make sure we still have a good consensus process in case they might weigh in differently, because he's not going to be able to speak for himself. He's cognitively impaired fairly severely. And things may change along the way, because no advance directive, including the POLST form, can take into account every imaginable of the infinite variety of things that might come up. So let's at least get a conversation going. In case things really go south, we might start invasive therapy like a ventilator, but we need parameters for when to stop it if things aren't working out. That's a great idea.
The Alzheimer's Resource of Alaska says it would be consistent because he might still want antibiotics and dialysis.
Sure, there you go. So, not so bad after all. This might be just fine, huh? It's at first glance you might think, oh, geez, we don't want to get this guy on the ventilator. But it could work out okay. It could work out okay. Yeah. Depending on how involved and the palliative medicine talents of your medical center and ER. A lot of intensive care providers these days don't see a huge difference between starting ventilatory support and withdrawing it. A lot of providers are actually pretty comfortable withdrawing after it's been instituted. A lot less angst these days about that compared to, say, 10 years ago. So they would look at this and say, that's not such a big deal. We can work with that in a lot of ICUs these days. So not so bad. Any more comments, Barb? Let's do another one. Here's a 58-year-old woman with metastatic lung cancer. She's actually in hospice. And she's in a very large multi-generational family. And ethnic minority group. They're all present, multi-generational, lots in each generation too. So she's got a whole bunch of children who have a whole bunch of grandchildren, even a couple of great-grandchildren to this 58-year-old. So well-loved, but she has metastatic lung cancer. She comes into the emergency room, and her POLST indicates that she does want CPR, but then wants comfort measures only. So those are the two top boxes. CPR, yes. Comfort measures only, yes. How can we negotiate this one? What do you think? Could that be a consistent, good internal logic POLST form, or is that just not going to fly? By the way, she's come into the ER. She's clearly very ill. She's running a low blood pressure, cachectic, short prognosis.
So if on hospice, CPR doesn't seem logical.
Yeah, can you be on hospice and be full code, so to speak? Is that possible? Maybe some of you attending work in hospice. I've stumped you.
Well, I would have a question about whether she's awake, able to respond to questions, if there would be an opportunity to clarify some of these.
Yeah, she's kind of in and out. She's kind of moaning and not very responsive. Yeah, but might be interactive at some point. Mm-hmm. Families all present seem to be very sweet people. Just very worried.
And then another comment is that it seems contraindicated.
To do CPR.
Yeah. Mm-hmm. Go ahead.
This seems like where you need to educate the family that maybe when there is a need for CPR, that's
Mm-hmm.
And this is the ideal thing to not want to do, maybe.
Yeah. So that comment was here that this is a situation where we need to counsel the family, bring them together, and indicate that, you know, it may be that this is her time and that CPR just simply wouldn't work, and it's not such a bad way to go now, that we can guarantee them that we can keep her comfortable. We'll honor her comfort measures only indication here, and included in that would be actually not using CPR in this instance because it just wouldn't work. So yeah, this one is probably internally inconsistent in this clinical situation. Do we have another comment?
Yeah, so you can, it says from Wyoming, yes, you can be on hospice in full code, but probably not common.
Right. That's my experience here in, I think probably across the country, is most hospices have a handful of people who are full code, and the hospice team takes that on as well. That's the beginning of the conversation. Let's carry on with the conversation. More often than not, that merges into something that's perhaps more comfortable and more consistent with hospice. Sometimes not, though, but all kinds of things can happen. But yes, it is actually a matter of legality that you have to admit people to hospice, since it's a Medicare benefit and Medicaid often, without discriminating in any area, including what their code status is. So certainly you can be admitted to hospice and want CPR.
And the Kalispell, someone from the Kalispell VA says it's the patient's choice which way to go.
Right, absolutely. So I think that's fairly consistent. So I think we've agreed in this case, well, we need to have a conversation with this multi-generational family, assess their feelings about things, their goals. If the patient becomes responsive, to bring her into it a little bit if possible, but to counsel them that the CPR piece may not be the way to go, wouldn't work in this situation, and hope for the best thing. You can use terms like, you know what, we will do everything that's even remotely indicated for your mom. Anything that has even the slightest chance of helping her. That actually would not include CPR right now, just the wrong tool for the job right now. But if we can, improve her comfort, we will stop at nothing to make her better if we possibly can. This isn't one of the things that's going to help us get there. Yeah, so just some language tools to use in that kind of situation. Very good. Let's do another. Here's a 62-year-old woman with advanced liver failure from hepatitis C virus, long-standing, and alcoholism. She is still an alcohol user, and she arrives in the ER hypotensive and with hepatic encephalopathy. She has a POLST form on file in the hospital in the ER that she wants no code, comfort measures only. It's signed by her physician, or a physician. Is actually illegible. You can't read it. It may or may not be a physician. Can't quite tell. And it's actually not signed by the patient nor any surrogate decision maker. Just this kind of squiggly line in where the physician signs. What do you think?
Not valid without a patient signature.
Other comments?
Kalispell VA says that's not always true.
Which part?
That it's not valid without a patient
Oh,
signature.
I see. Responding to that. Yeah. Mm-hmm.
Or POA. I'm not.
Power of attorney.
Oh, power of attorney.
Yeah. Yeah. Well, you could go a couple different ways with this one. You could say, you know what, we've got a 62-year-old with very advanced liver failure, very bad prognosis, hypotensive, encephalopathic. Let's just say she doesn't have an advance directive, and go with that. Do the best we can with this patient. Maybe we can get her encephalopathy a little bit better, give her some IV fluids, see if we can bring her around a bit, and seeing if this is something she recognizes or not.
So someone has said you must treat.
Yeah, maybe with what I just said. Okay, yeah. It's a tough one though, huh? It turns out in this particular case, she did receive IV fluids and lactulose. Actually, her rectum, yeah, lactulose enema. And actually came around. It took about 6 to 8 hours, but her blood pressure actually was easy to bring up a little bit. Her other vitals were okay. And she actually came around a little bit. And somebody said, have you ever seen this document before? She says, oh yeah, that's my dirt mat. That's what I want. So, worked out okay. Then I said, well, okay, if that's what you want, why don't you sign the darn thing? So I'll get around to it when things get bad. Go ahead.
Those are comfort measures, what you did, right?
Yeah, you could construe it that way.
We've sent several people from the jail to look about like that. And better.
Yeah, the comment here was that, well, what we did, IV fluids and lactulose, could be construed as comfort measures. So we were kind of following what we were presuming to be her POLST form. So it actually worked out okay in this particular instance, and I think the comments are fine. Just, you know, we're getting the feel, and probably a lot of people listening in have seen that the POLST is not infallible, that some of these cases kind of fall through the cracks and drive you nuts a little bit. But what's great, you know, hearing from people around the Northwest is this pretty consistent feelings about the whole thing. So I'm getting the feeling that a lot of the people listening in and attending today, you know, have a lot of experience with the POLST and have dealt with some of these issues before, which would not be unusual. Okay, let's try another one. Here's an 88-year-old fellow with advanced COPD and CHF and moderate Alzheimer's disease. Pretty bad, actually. Admitted with severe dyspnea. So he's come through the ER. He's in the holding unit for the ICU. See if we can get him a little better, in which case he could go to the general ward, or if not, go into the ICU. His POLST form says DNR, do not resuscitate, allow natural death, comfort measures only. He is nonverbal with his dementia and his severe dyspnea. His daughters are present in the area. They're both lawyers, turns out. They demand full treatment, CPR, stating he could not possibly have meant that on his POLST form. They know what a POLST form is. That's not what he meant. They don't know how this thing got filled out. Yes, it's signed by his doctor and by him, but you know, he has Alzheimer's disease. That is not what he meant.
So there's a question that asks, when did he sign the POLST?
It's dated about 6 months ago, if that helps you. Not too far. I mean, it's not like 10 years ago or anything, but...
if properly filled out, attorneys have no say.
Go ahead.
I'd say someone who had moderate Alzheimer's and signed up 6 months earlier, probably not competent to sign one.
Comment was, if this fellow signed a POLST form 6 months ago and had moderate Alzheimer's disease, he may not have been competent to sign one. Feel free to chime in if you...
Question is, are the daughters his POAs?
Yes, the daughters are his next of kin. So in Washington State, they would be his legal surrogates. Yes, if he couldn't speak for himself.
Can you talk a little bit about decisional capacity in the context of
Sure.
mild to moderate Alzheimer's?
Well, sure. I'll take that one on. You know, decisional capacity has to do with what the decision is. You know, none of us were there when presumably he sat down with his doc and went through this POLST form. If people can hear what you're saying, take it in, think about it, and render a decision that's clearly based on what they've thought about, then they have decisional capacity for that item. So let's say that I'll make up a hypothetical conversation for this physician and his patient. Let's say the patient was better at the time, but still was moderately demented. He's sitting down with his doc, and the doc says, "Look, Bob, if your heart stopped beating, would you want us to try to bring you back with the CPR?" And he says, "No, I don't want any of that stuff. If I'm dead, leave me dead. I'm okay with that." I would make a judgment, and this is just me, that he has decisional capacity for that item. Now, let's say the doc goes on and says, "Now, Bob, you've got a really irregular heartbeat, and in this situation, we usually like to put in a pacemaker to make sure your heartbeat doesn't go too low or too high." And Bob responds with, "You know what? I've been thinking about buying another car. And so, by golly, based on this, I think I'm going to do it. I'm going to get a Chevy Malibu." Well, he might have heard something of what it was proposed, but that might have been way too complicated a decision for him. And I'm being slightly facetious, but not entirely, you know. So he comes back with that. That is clearly not based on a good understanding of what the doctor was talking about. So it may be that the conversation was forced, and, you know, maybe the daughters are right. I mean, that's conceivable. They probably know him better than the doctor does.
So some comments include the fact that someone has said that the fact that the daughters are the POAs changes the situation. And someone from Seward has said his physician should have evaluated his cognitive state at the time of signing. And someone else says, why would the doctor have signed the POLST if the patient wasn't competent at the time?
Yeah. Well, this is another opportunity for consensus building. So it depends on, in the heat of the moment, you're there with the daughters. Presumably you've got a little time to kind of stabilize things and try to vet this a bit. And what you can do is empower the daughters and say, you know what? You're his daughters. You are his legal surrogates. We are recognizing, acknowledging, and embracing that you're in that role. So we don't want to give you the impression that we're not paying attention to you. Let's get a hold of this physician if we possibly can and see if we can get that person on the phone and talk this through together right now if we possibly can. So I'm going to go try to do that and see if you can build some consensus. Now, chances are you might not be able to do that, might not be able to get hold of this person. But if there's a ghost of a chance, that might be an opportunity for some consensus building. If the daughters are actually hearing from the doc, you know, hey, I sat down with him, we talked this through, and here's what he said. I recognize you're his surrogates. You might be able to change it, but by golly, we had a good discussion about this. I know he has Alzheimer's disease, but we talked about this, and he knew what he was saying. You know, if you get that back, the daughters might say, oh, well, geez, you know, okay, maybe so. They still do have the power to countermand it as his legal surrogates. They can change his POLST form. So this is a potential glitch. You know, what we're not given lip service to here is the hundreds of thousands of times the POLST form is acknowledged and it works just fine. I mean, that's the norm. We're pulling out these weird cases today to just show that it's not infallible and to actually, I mean, we're demonstrating to each other through this session that there's actually ways to work through these things when the glitches come up. So, not so bad. What actually happened here? Well, it turns out they were not able to talk to the doc at all. They were able to talk to the partner, and it turned out the physicians actually had kind of a palliative practice of some sort, and the partner thought that the physician probably wouldn't sign it unless he thought that this was a reasonable decision. The daughters still had questions, but they were able to talk through things with the team and said, well, let's kind of see how it goes. Turns out the guy actually recovered. He actually didn't need ventilatory support and, you know, was in the hospital a couple of days, but kind of got over it. Got diuresed, got some bronchodilators. Wasn't any more conversational about this because he was still kind of sick, but at least it allowed time for the daughters to kind of go back, think about how sick he was in this instance, and actually at least take it back to the physician, presumably, at a future date to talk it through. So I don't have a resolution for this case. was just so, sometimes there's time to work things through. You don't have to just nail it down, 100% at any given instance. And this was a good example of that kind of thing. Let's do another one. What do you say? These are fun, huh? To me, maybe not to you. Here's a 58-year-old man with advanced liver failure, another end-stage liver disease from alcoholism, mildly encephalopathic, but conversational, a little bit sleepy. He's got a POLST form that's a couple years old that says he's no-code comfort measures only. He actually came into the ER from a nursing home and now has a more recent POLST form that says CPR full treatment. Both forms are signed by him, and both forms are signed by a provider. What do you think? Just go with both of them?
Is there a reason you would hesitate to go with the most recent one?
Depends on how he does, We're just kind of trying to figure out where to go with it. This guy isn't hideously ill. He's just a little encephalopathic, conversational, sleepy. Yeah.
So someone has said if he's conversational, discuss it with the patient.
There you go. So nothing like just say, hey, here's two forms. Which one? These aren't consistent. Especially if you can get him to wake up a little bit like the other patient, where she was able to wake up. She was sicker, but this guy's not quite so bad off. Maybe we can wake him up and discuss it.
And then we got the comment that the newest one is valid.
Yeah, presumably on the face of it, you should go with the most recent one, right? Now, a lot of skilled facilities do use the POLST as their form. Many of you may work in nursing homes or have worked in nursing homes, and you realize that when if that's the form for the nursing home, if they use the POLST, and a lot of skilled facilities do now, that's their advanced directive form. But when you enter a nursing home, you go through a whole lot of stuff, and it's real easy, especially if you're ill, to kind of your eyes to glaze over. I mean, you basically sign your financial life away. You go through these big, long legal forms about that. You choose your funeral home. You choose your advanced directive. Your surrogates, all kinds of stuff gets done, and you sign this stuff, and you're maybe not quite sure what you're signing sometimes. It's like buying a house. I bet many of you have bought a house. Did you know what you were signing when you signed your mortgage? These 18 forms, legal size. No, nobody reads that stuff. You just sign it, right? So they give you the money. Same with this kind of thing. So you wonder sometimes about the advanced directives when people come through. Anyway, what happened here was just that. Both forms were shown to the guy, and he said, well, actually, I don't remember signing the one from August, so let's go with the first one. But it could have worked the other way around, But he was able to wake up. It wasn't until the next day, though. It wasn't when he first came in. So a little bit of ambiguity for a day or so there. But it worked out in the end. Okay, let's try this one. Here's a 57-year-old physician with advanced pancreatic cancer. He dutifully has his POLST form. He's do not resuscitate, do not intubate, but full treatment. In other words, no CPR if it's found dead, but full treatment. He arrives in the emergency room after a suicide attempt with a self-inflicted gunshot wound to the head. The neighbors heard the discharge of the firearm, called 911. He was resuscitated and intubated in the field. And EMTs, it's for suicide. They don't care what any form says. They do their thing. He brought into the ER. What do you do with this? Sad situation. Mm-hmm. These are all real cases, by the way. These are not made up.
Is part of the dilemma whether you take him off of life support then?
Yeah.
So someone has said full treatment, question mark?
Yeah, full treatment. Ventilation, pressors if necessary, full treatment. Includes all that stuff. full ICU support, just no CPR. Very sad situation. It turned out this physician wanted to donate his organs. So his idea was, he had like a little letter was found in his kitchen late, like a few hours later after he came in. And his idea was, okay, I'm going to take myself out now while I still have good organs, and somebody else can use my organs. So that was his apparent thinking behind this. And that did not come to pass because he deteriorated. His cancer was actually pretty far advanced. But that, that actually, it turns out at Harborview, this has come up more than a few times where people have committed suicide with POLST forms, kind of like this. And it's very difficult. But that was the underpinning of this particular case.
Interesting. I don't have any other comments.
Okay. It's almost too sad to comment on. It's just a tragic kind of deal. Here's a similar one. 89-year-old man is full-time caregiver of his spouse with dementia. His POLST form says DNR, comfort measures only. He also arrives in the ER, gunshot wound to the head, suicide attempt, intubated in the field, suicide letter and phone number for the lawyer left near his body.
What was in the letter?
That he just couldn't live like this anymore. Here's the number for my lawyer.
And the comment says, just don't call the lawyer.
Yeah. Well, it turned out that his lawyer had detailed instructions about what should happen to his spouse if his death preceded hers. So it was basically a regular old suicide in the setting of caregiver burnout. But he had taken care of things and had provided for his spouse to be cared for via his lawyer, who was basically acting as a carrying out his wishes for him post-mortem. So, sorry, but some of these cases are really sad. But you can see how lay people are using the POLST form in ways that we as providers may not have originally intended. And the more pervasive POLST forms are used, the more likely these kinds of things are that might come up, where people kind of fall through the cracks or use them in ways that we have to interpret and make sense of later. So, interesting case. Well, just to finish up here, here's the penetration of POLST forms as of almost 7 years ago, a little over 7 years ago. And you can see where established programs are. I'm sorry I don't have a picture of Alaska or Hawaii on here. But clearly this isn't up to date, because we have folks on the program who are from Montana, Wyoming, etc., who are familiar and are using the POLST form. So there's much more penetration than this graph would indicate. And the developing programs are probably fully developed by now. It wouldn't surprise me if there's kind of national homogenization of this over time. But there's remarkable differences in the way these are used across the country these days. For instance, probably a lot of people participating today realize that nurse practitioner practice varies quite a bit still from state to state. It's also becoming a little more homogenized over time. Probably sometime in the next decade it will be pretty similar. But it's taken a lot of time to homogenize nurse practitioner practice from state to state. I don't know, Barb, maybe you know, but can nurse practitioners practice in all 50 states now?
Well, they can practice, is my understanding, but prescriptive authority differs.
So, and there was a time not too long ago where states maybe wouldn't even license nurse practitioners. Now, maybe that's 15 years ago, but that's been slow in coming. So, things change over time, and much less sign a POLST form, which is dumb. Obviously they should be able to do that, but things change over time, and I think that the state map would look a lot different today if we reassess this. I think there'd be a lot more pink and red.
Are some of the little splotches in a state like counties that have passed a law or something?
Or regions, sets of counties. So you see Wisconsin there. That big red blotch is around the Mayo Clinic in Rochester. So it varies by but I dare say even within states, like even within Washington State, I've seen some variability in how the POLST is used, interpreted, etc. So it's still developing, still homogenizing. On your slide set, which I think everybody has these, right? Here's a bunch of web resources for you, including polst.org. You guys should, after this talk, why don't you take a few minutes and go to that website, because I bet there's an updated map, because this is a national intervention. And a bunch of other things here. There's the West Virginia Center, Washington State Medical Association, POLST, Compassion and Support from New York State. So lots going on around the country around this and similar things, which is interesting. And the conversation and use of the POLST is evolving in slightly different ways in different areas of the country, clearly. It's just kind of interesting to watch this over time. I began my career when the POLST was first coming out, and it's been very interesting to see how it evolves over time. You providers up in Alaska may remember a time where the state of Alaska didn't have any laws for surrogate decision making. That was not that long ago, but now they do. And even those laws are different in the Pacific Northwest. Very similar between Washington and Montana and Oregon. Actually, Oregon's differs from Washington State. In Washington State, it goes, let's see, it's guardian, after the patient, there's guardian, durable power of attorney, spouse, let's see, children, parents, siblings. In Oregon, I believe below that is close personal friends, which I think is cool. I think that's great, because often that is a totally legitimate surrogate, as good as a family member. It'd be neat if that pervaded more states. Currently, that's not part of Washington State's surrogate decision making, but it varies from state to state. So that's kind of interesting. Some resources for you. Okay.
Okay.
It's 5 p.m. Any comments from the group? We've got a few minutes. If not, I will let you go on this beautiful spring day, but I'm happy to stick around and answer a few comments.
Two gunshot cases, suicide, how do they end up? Do they end up pulling the plug later?
Yes, the question was about the two gunshot wound suicide cases. In both instances, the patients died the same day they came in. So they came in, were evaluated. It was not a remediable circumstance. No organ donations in either case. I mean, the first fellow had widely metastatic cancer. It just wasn't viable. Even corneal transplants couldn't be put together in time, which is tragic because that's clearly what he intended.
Seems odd that as a physician he wouldn't understand that. But
yeah, well,
could be when he signed the form, perhaps.
Yeah.
There's a question here. Why does the POLST indicate the patient's surrogate signature is optional?
It's for consensus purposes. It's okay for lots of people to sign the POLST form. It doesn't have to be just the patient and just the provider. it's kind of good. Now, wouldn't it have been nice if the lawyer daughters had co-signed the POLST form for the old bird with COPD? But no, it was just him. So it's just the option to have others sign it so you know there's consensus. I kind of like that. It'd be nice if that was a little more explicit and solicited maybe more actively. It's also a good idea on POLST forms. Let's go back a bit. The new ones are nice because there's actually more spaces in it. There we go. You can see even here in the B area, there's a space for additional orders. And there's a little bit of blank area next to C and D. The new forms are a little bit more explicit. And even down below, there's summary of medical condition. There's more spaces to more overtly solicit more pros on a POLST form. Like, you might say, let's say it was one of these POLST forms we reviewed where it's do not attempt resuscitation but full treatment. Somebody might say down in additional orders, I want you, if I actually got pneumonia and needed a ventilator, it's okay to try it for a couple days, but if it looks like it's not going to pan out, just let me go. If some elaboration of what the actual intention is, can be helpful. So if that's appropriate, it's probably a good idea to jot down anything additional actually on the POLST form before it's signed, just to provide a little more detail, elaboration of these kinds of things.
Is there any sort of a competency checkoff box or anything on these?
No, there isn't, and there never has been, and that was...
Repeat the question.
Oh, the question was, is there any checkoff for the competency, capability to sign the form? There's not, and that was actually an explicit consideration, and decision was made not to do that. The thinking being, if somebody signs it, they're asserting their capability to do so. So they decided not to address that because it's not a yes/no so much as kind of a squishy area in the middle, and so they thought this was probably not the appropriate place to put that. And the history of advance directives and living wills are such that it doesn't really appear on them either. You're assuming that if somebody has a living will, they knew it was in there and signed it. So that this goes along kind of with the historical infrastructure of living wills generally. And it was decided not to do that. So, interesting.
Kalispell says, nice case studies.
Yeah. I'm not sure I'd call them nice. Interesting, maybe. Thank you for that comment. Okay, everybody. Well, thanks for coming. We'll end a little bit early, and have a good dinner. Take